Welcome everyone to tonight's Murray PHN webinar. We're delighted to be able to share with you the remote patient monitoring program which Murray PHN has in place, and to show you what the recent data or the new data is starting to reveal about the program, and to also share some of the learnings and some of the mechanisms we've put in place to help the remote patient monitoring to help you and to help our patients. So I'd like to begin though by acknowledging the First Nations people and the country that we are on. Murray PHN acknowledges the traditional owners of the land on which we work and live. We recognise, celebrate and respect Aboriginal and Torres Strait Islander people as the first Australians. We acknowledge their unique cultural and spiritual relationships to the land and waters as we strive for healing, equality and safety in healthcare. We pay our respects to elders past, present and emerging, and extend that to all First Nations people who may be with us today. I would like to start by just giving a very brief introduction to our remote patient monitoring story so far. The whole RPM program has come about as an innovative approach to reducing potentially avoidable hospitalisations. There was a very large CSIRO study done about 6 years ago now in remote patient monitoring as a strategy for helping with the care or the coordinated care for people with chronic disease. And it showed some very significant health economics in improving, not just with improving patient care, but with the health economic side of it for reducing hospitalisations, for admissions and for ED presentations. But of course, it's the patient care experience as well that improved chronic disease management produces. We started with an RACF trial. We thought if we're going to trial this, we're going to trial this in a really genuinely tricky setting, in the sense that we went to more remote parts of our catchment, very rural locations across multiple sites. We had 7 sites in that first trial, and it was specifically for for residents with chronic disease who were in residential aged care facilities. Bendigo Health provided the remote monitoring component. Tunstall were the system that we used, and Murray PHN were the commissioning body. We then we learnt a lot from that trial, and we moved across into working with different multi-layer health sectors. So we went with large regional hospitals, small rural health services, ACOs, Aboriginal Community Controlled Health Organisations, and with a large PCP primary care partnership up in the northeast of our catchment. We learned many lessons from that trial, and I'm going to share those with you. But the biggest one of all that we learnt was to reorient our remote patient monitoring program to focus on smaller and localised clusters, particularly at the primary care end of the management, as opposed to the hospital subacute end. So the key lessons we learned from those 2 trials: remote patient monitoring can be done. It works, it can be done regionally, rurally, and across those different layers of health system. However, it's better to invest in supporting clients in their own home rather than waiting until they're in residential aged care. It's better when it's in smaller localised clusters rather than in larger health services where the red tape becomes significant and the ability to change and modify to meet the needs is more restricted in the larger organisations at times. We learnt the equipment needs to be simple and agnostic as possible. Our first trial, we had a very different setup and very different unit that was certainly more complicated than the current iHealth devices that are being used. And the other very big learning was that it's just as much about building health literacy, patient health literacy, that understanding their own health condition, what they can do, how the small things they do in daily life can assist with their vital signs and their health. It's just as much about that, if not more, as it is about the remote monitoring or the remote support. But it's put together that we have this remote patient monitoring program. And the little wordle or the word cloud on the right-hand side of the slide is what the patients said in those first trials about how they felt about being a part of a remote patient monitoring program. What I'm going to do now is hand over to Aileen Lai. Aileen is the CEO and founder of HealthBeats, and HealthBeats provide the care monitoring platform for our remote patient monitoring program. Following Aileen, Aileen will hand over to Craig Simmonds, who is the CEO and founder of Propell. And Propell is the Australian, I hope I get the right word, distributor of the eye health devices and of the HealthBeats platform. And then Craig will hand over to Suezanne Martin, who works with myself at Murray PHN as an integration coordinator. I'm sure all of you or most of you will have had contact and worked with Suezanne in setting up your remote patient monitoring programs. Okay, Aileen, over to you to share the really interesting data that's been coming into the program.
Sure, thank you so much, Bronwyn. Thank you. So a very good evening to everyone. My name is Aileen. I'm the CEO and founder of HealthBeats. I'm very honored to be here to share the data that we have actually consolidated over the last 5 months from January to May. And without further ado, so let me just do a very quick introduction. So I'm sure all of you use HealthBeats as the platform. So we are a global remote vitals monitoring platform. The whole idea is to actually try to support our healthcare professionals in bringing healthcare home. So in our solution, we actually provide the medical devices. In the Murray PHN project, we provide eye health devices to be self-administered at home with the platform and end-to-end support services. So we hope to have their results transmitted real-time to care providers for proactive care management. HealthBeats also is a global distributor of eye health full range of medical devices, as well as another brand called Endisfit. We also use in-hospital devices such as HealRoom for remote monitoring as well. So we actually advocate a full range of devices from BGBPs, SpO2 thermometers, fitness devices, spirometers, as well as Holter. For the Murray PHN project, there are 4 devices that are slated for use. One is, all of them are under the eye health brand, blood glucometer, blood pressure meter, weighing scale, and pulse oximeter. So without further ado, let me go into the actual data presentation. So the data will be presented at the Murray PHN at the global level. We are, except Ithaca, we are not presenting the data on every individual health service basis, but the data actually present very interesting findings. So let me give a very brief background to keep everyone on a common note to understand how the data come about and what are the bases that form the data. So number one, let me run through a very brief background. So the first health service was deployed in October 2020. So that was last year, October. And by March this year, which is about approximately 5 to 6 months, we have 17 health services that were successfully set up. So kudos to all of you in supporting the program. We were able to set up successfully in a short time. By today in July, we have a total number of 20 health services in the program. So the objective from a HealthBeats perspective is we are here to support the overall program efficiency and efficacy through program tracking, improvement, and measurement. So the data is really, the objective is to provide quantitative information, because success of the program comes from qualitative as well as quantitative. So we are confining it to the numbers that we have in the platform from a quantitative perspective. So there are multiple areas of the data, what we are trying to identify. Number one, we want to identify the key demographics of our patients, of the patient of the Marine PHN project. Who are they? What is their age? And so on and so forth. And two, we want to identify patient adherence. Are they measuring? Are they facing challenges? Three, what is the indication of the process outcomes? For example, threshold alerts, as well as, for example, critical high, low, or miss alerts. That is part of patient adherence. And four is actually the interesting part is the data actually reveal some common assumptions that we have, and it is set to actually affirm or to debunk some of the assumptions that we always have. So the data, as like all data sets, I just want to make some key assumptions. Whilst our program started in October, but due to the initial implementation and deployment, there is bound to have hiccups, ups and downs. So data is cleaner with time as time passes. So our data analysis was started in January to May this year. So it is a 5 months data. Number two, because we were testing out to look at what analysis we can do, we only use true data. So we did not apply a standard deep data analysis techniques, for example, normalization of data, filtering of data, fixing of, for example, potential errors, or all other data cleansing techniques. So whatever data is taken, it is at its. Next, as the program stabilizes, we believe the data will stabilize over time as well. So based on this assumption of 5 month data from January to May, the first part we want to look at is actually demographics. So in terms of the number of health services, since January to May, we have about 100% increase. Total to date until May 2021, based on the data, we have 16 health services. So also from January to May, we saw an increase of 82% increase in the number of patients enrolled. By end May, the total number of active patients enrolled is 80. So out of this 80 patients, Echuca Regional Health, our user acronym ERH, has the highest number of patients enrolled. In terms of enrolled patients, we have 80. And what about discharged patients? We have 13 number of patients enrolled. That is 14% of enrolled patients were discharged. So we also came out with a category called inactive patients. So we noticed that there are patients who actually were onboarded, they were enrolled and onboarded, but they were enrolled, but they did not even onboard. So they did not download the app in their mobile phone. So they are considered as inactive patient, means they have not taken a single task. Second category of inactive patients are those who did not take a single measurement since they are enrolled. And third category of patients that are inactive is in the past 3 months, they did not take any measurement as well. So as of May this year, we have 23.75% of patients, which is 19 patients, is inactive, as compared to 18%, which is 8 patients in January. We have a higher number of patients, almost the same percentage, because there are more patients as the months pass. I just want to also add a note, is that inactive patients significantly impact adherence rate, which we will touch on a little bit later. This is a very, very interesting slide and a little surprising for me. So when we start to decipher and look at the demographic of patients by age, so we always believe that the higher the age group of the patient, they have more challenges in embracing technology, Bluetooth pairing devices and smartphones. But very amazingly, collectively, all the health services have 63.75% of patients age 61 and above. So we go for the challenging group, right? And we have a large 10% of patients age above 80. So we were able to prove that patients defy the fact that even patients with age group, they are able to overcome technology and were able to embrace the program. The overall mean age of our patient is 65 years old, which is generally higher than a lot of other projects that we have. All right, and in terms of patient by their sex, male or female, that is insignificant difference. We have almost equal number. Okay, So we further dissect them into programs and devices because we are keen to look at how many programs they have, how many devices, and what devices they are having. So by the number of patients by number of enrolled program, it is great that almost all of them have one program. It meant that because one program can have multiple, we can allow multiple devices to be enrolled in one program. And we noticed also over time, there are more multi-device programs set up and enrolled. So most patients, if you notice, has only one program. The rest of the patients have more than one program, is highly likely that they have acquired another chronic disease and have to add on a new program to help them to monitor another disease. The number of patients by the number of devices. So again, we always have the perspective that the more devices a patient has, the less inclined they are to use it. So as of May 2021, we have 45% of patients assigned with one device. In other words, all the rest of patients, the other 55%, has 2 or more devices. So majority of our patients today generally has more than one device. And by the device type, the most common type of device assigned is the blood pressure monitors. The rest of the devices, BG, pulse oximeters, weighing scale, are not significantly different as you see from the chart. So the first section of the data actually looks at demographic. Who are the patients? What are the devices? How many programs they have? How many devices they have? And so on and so forth. So we are currently moving into adherence. So adherence, by definition, we adopt a simple adherence definition. Number of completed tasks divided by total number of tasks that is assigned to them. Something very simple. So number one, if we look at overall adherence before we delve into the details, from January to May is at 36.54%. 36, I just want to qualify that 36.54 is not low. It is because number one, it is impossible to reach 100% adherence because number one, there are patients that are inactive. Number two, there are some patients that will always miss certain tasks. Number three, there are cases where patients are rehospitalized and they're unable to measure. So for a lot of reasons, usually the benchmark that we set for ourselves as HealthBeats is about 40%. Okay, so but the thing is, if we exclude the 19 inactive patients that I mentioned and defined just now, those that are onboarded, and those who never did not onboard, did not take a single measurement, or did not take any single measurement the last 3 months, the overall adherence rate moved up to 45.45%. So it's a very significant jump if we are able to address the inactive patients. Across the month, overall adherence rate has insignificantly increased by 7.12% in March, but it dropped by 3.56%, 4.94 in April and May. We want to make a note that the number of care tasks increased significantly, as you can see in the table, in April and May due to the increase in number of patients enrolled. So every time when they start to enroll, we will see a lot more tasks, and also the adherence rate initially will not be met, and slowly they will pick it up. Okay, next paragraph is 60. When we start to study across the health services, it is heartening that 60% of health services were able to hold up an average adherence rate of more than 40%. And with 33%, 1/3 of health services achieving more than 60% overall adherence rate. So 1/3 of health services were able to hit more than 60%. That is very impressive. And 3 health services were able to hold adherence constant across the last 5 months without a drop, keeping the patients engaged. Last and not least, in all my subsequent data, in order to maintain neutrality, all adherence analysis includes inactive patients. Okay, so it will look lower. All right. Okay, so just now we said that we go after the hardest age group, the high age group, form our largest cohort of a patient in this project. Then the next question it would be, since we have so many patients, majority of them at age 60 and above, Are they measuring? Are they facing challenges? They might not be measuring. As of May, our age category, age above 80, scores the highest adherence of 49.08%. So we have the hardest age group with the highest adherence, which is very, very interesting. And we have age 61 to 80 as the third category at 33.34%. For age 41 to 60 has 38.69%, but they improved 156% as compared to January. So we see a large improvement for age 41 to 60 in terms of adherence over the 5 months period. So we have tried to understand the myth about age and adherence. Now we talk about adherence and the number of devices. We always believe that the more devices, the less inclined for them to measure, which is a common trend. So it's commonly believed that the more measurements we prescribe, the more deterring it is for patients, that this led to low adherence, right? So we start with one device. One device in January started with a very high adherence, but across the month to May, April and May, they show considerable decline over time. But as of May, the highest adherence is patient with 3 devices at 37.98%. The rest of the number of devices, 1, 2, and 4, does not have significant differences. So we have our patient with 3 devices with the highest adherence. It might be due to their health condition, and probably also linked to the age group where they are more inclined to measure consciously. And we also try to identify what are the devices that patients really don't like to use, and those the ones that they really love using. I wouldn't say love using, but they are willing to use them regularly. So as expected, this is in line with expectation. BG, in being invasive, presents the lowest adherence rate. So there is no significance in terms of between BP, pulse oximeter or weighing scale. But in May, the month of May, BP has the highest adherence rate of 45%. And over time, compared to January, we saw a large increase of 43.3% improvement in terms of adherence. So that is very significant. Okay, so with the first category, understanding the demographic and the categories of clients or patients that we have. The second part, trying to understand, are they measuring, and what can we potentially do based on data to improve that? And then now come to the third and last category, is the outcome, the process outcome in terms of threshold. So in the HealthBeats system, directly related to outcomes are threshold alerts. So if you can recall in the system, we have critical high, critical low, high, and low. There are 4 thresholds, so we analyze them across the 4 categories. So overall, our threshold alerts are hovering around 13 to 21.4% across the 5-month period. So in the first place, the threshold alerts are not very high. So it could be a conscious effort to, in terms of behavioral change, to maintain their readings. I'm not sure. So probably the health services will know much better than me. Number 2 is, if you look at the critical high readings, there was a spike in February at 21.4% of measurement. We also noticed in February there was a huge influx in enrollment of new patients. So that could have contributed to an increase and spike in the critical high readings. But in May, by May, in 3 months down the road, it dropped very significantly to 38.3%, significant at 38.3% to 13.21% in May. So with an improvement in terms of number of critical high readings from February to May, we will expect from critical high, some of the critical high threshold readings alerts will move into the high threshold alerts as they start to taper down. But for high readings, March, April, and May show consistent reduction at 6.3, 9.4, and 15% respectively every month, despite we expect them to increase because critical high readings are reducing. This meant that both high and critical high readings alerts overall has been trending downward across the last 3 to 4 months. And if you look at how significant for consistently for the last 3 to 4 months, we do not analyze the low and critical low because they are very low in the first place in terms of thresholds. Okay. So after we look at the overall threshold numbers and the amount reduction across board, we start to dissect them into various categories. So the first category is by the type of device. Are we seeing a reduction in BG, BP, pulse SpO2, or whether it's weight? So BG and BP contributed mostly to the threshold alerts. Pulse oximeter and weighing scale far less. So we zoom into BG and BP to look at their statistics. And interestingly, although BG is not commonly measured, they have the most significant contribute to threshold alerts, but they also show the most significant improvement. So if we compare February to May, there is a 361% increase in critical high threshold alerts for BG. So this is huge. So we noticed that BG enrollment increased across the months. So this is likely due to consistent increase in BG enrollment between February to May. But there is a very large 75% reduction in critical high threshold alerts for BP. That is very, very big jump. And a 58% reduction in high threshold for BG, 7.2 reduction in high threshold alert for BP. So if we combine both high and critical high, generally considered as thresholds, for both BP and BG, from March to May, there was a huge 51% reduction for BG and 43% reduction for BP. We were able to reduce number of BG threshold alert by half and almost half for BP. Okay, in summary, summarize what I've said in the last 20 slides. We have a total number of 16 health services as of May, 93 total number of patients, out of which 13 are discharged, 19 are inactive. So we have 75% of number of patients aged 61 and above, 10% of total number of patients above 80. So define all, we have largest number by age group. Okay, overall adherence rate is 36, and for excluding inactive patients, 45.45. Overall, age above 80 scores the highest adherence at 49.08%, and also from patients with 3 devices at 37.98%. BP also has the highest adherence, BG has the lowest. Overall thresholds alerts hover around 13 to 21.4%, but across March, April, and May, we are able to see constant reduction of 6.3, 9.5, and 15% respectively. Last and not least, the overall combined reduction in high and critical high threshold for BG and BP over a 3-month period is 51 and 43% respectively. The last slide I have, and not the least, is a very quick afternote. As we continue to churn out and generate data, I just want to put some notes in terms of the data. So first thing is data is highly dependent on what is input. So we want to share some of the best practices we have here. For example, if we can proactively adjust the frequency of measurement according to patient need. If patients are not measuring, there must be a reason. If it's a technology issue, we are more than glad to support whatever we can do to help in terms of patient adherence. So if we are able to adjust frequency to patient need, that helps to improve patient experience as well. Number 2 is when there are inactive patients, we also would be great to know why are they inactive. So for example, it might be the frequency is too high, maybe for any reason, it could be device, it could be anything, is to find out and to reduce the number of inactive patients. So data are like that. So if I have a patient with 100% adherence, measuring every single task, and I have just another patient with 0 adherence, overall adherence will become 50%. So it does impact results. Third is if there are any adjustment to patient program, from the platform, it is structured to support best practices. So for example, we always use the edit function, because if we were to discharge patient and enroll them again, the data will go into discharge. As the system, when we are churning tens of thousands of lines, we are unable to determine which 2 patients are the same. So we will just have to generate the data accordingly. Fourth is not to create patients to test the system, because test patients does not fulfill measurements. So we noted that there are some challenges you face, and I think in the next session, Craig will actually present some of the improvement to the system and the solution we have to try to support you in your journey in remote patient monitoring. I mean, if there is any clarification, any feedback, any way you really want to have a support from HealthBeats, feel free to reach out to Craig, and to see, we will always see what we can do to support your journey. Thank you very much. With this, I'll hand over to Craig.
Hi, everybody. First of all, thank you so much for being part of it. We really do appreciate it. I will have seen most of you over the last 12 months as I've come to your health services multiple times. Thank you very much for being part of the program and making a difference. We've seen the data, which is making an impact. Just some other data, actually. We've got 80 patients enrolled to date. We want 220. So we want another, 140 patients onboarded in the next 6 weeks. And Suezanne and I are going to help you do that over the next 4 weeks, which we'll go through shortly. We've had some really great impacts on your patients. A couple of months ago, one of the clinics saved a patient from a potential cardiac arrest. The patient was using the Feel iHealth blood pressure monitor, and I actually remember this because we enrolled the patient together, a big burly bloke, and he of course didn't think he had any health issues, and the nurse kept on seeing the alerts daily, and the nurse and the doctor decided to get the patient in, and they changed his blood pressure medication straight away, and they said it saved a potential heart attack. And that's what this program is all about. This guy had no idea, now he does, and was very grateful, but what an impact that health services made on this patient's life. Some of the other feedback we're getting, and it is so much patient driven, is because the patients are monitoring themselves daily, they wouldn't get these type of things in any other format. Because Murray PHN have been able to give the device to the patients, then they know that it's part of their routine now. And what that's doing is it's reassuring them that they're controlling their condition. And that human behavioural change is so important. The other thing that we're also finding is that patients are saying you're actually got a much higher level of care from the health service. So what you're providing to the patient is far greater than just the, every time they come in every 2 months or whatever it might be. So they really appreciate the fact that you guys are monitoring them continually. That peace of mind is really important to reducing their anxiety. And of course, we want to make them healthier as much as we can. Some of the things that have come out from the data that Aileen has provided is, we know that those patients who are 60 and above, and even 80 above, are far more are great with the patient adherence. The other thing that's come up is very much the blood pressure. We really want to focus on, we know that we're getting really good adherence on blood pressure, and a lot of the findings we've had is when we first started to enroll really 12 months ago and over the last 6 months, is we've focused on sometimes getting a lot more devices on. I think the behavioural change is, it's for some patients, getting more devices on is actually hard. So I really suggest is, let's just stick with one device. Let's stick with the blood pressure monitor, or even stick with the pulse oximeter. Do the blood pressure program, do the COPD program. Just stick with one device, because we know that one device is going to get a better patient adherence. Apart from the numbers, and the numbers will never tell us what you're experiencing, what we've found is it's great. We've got all this momentum, which is great to now, but we're in that midway zone. We want to go, all right, well, we've got that first start. How do we re-engage, and how do we get more patients on board? Suezanne's going to tell you about how we can do that in terms of finding the patients. But one of the things I suggest is, because most of your health services have gone through staff changes, it's nothing to do with the patients. It's you've had changes. The providers that are doing the monitoring are no longer monitoring. So what we want to do is we're going to give you a call in the next couple of weeks, in fact, next 2 days, to organise a time to get you re-energized, get some more providers on board. So to help you if you've had a staff change, show you how to get a new provider on board, so some extra staff, so to help monitoring. And then we also want to make a difference to show you how we can get some more patients. So we do want to get from 80 to 220 patients in the next couple of months. But thank you for making such a difference to your patients' lives and helping your patients. We really appreciate it.
Thanks, Craig, for giving us a bit of an overview of where we're sitting with patient feedback and staff feedback. And I just wanted to quickly touch on what we're hearing back from practices around identifying patients and finding who they are. So RPM in general practice is aimed at supporting up to 10 patients. We know there's certain criteria. They need to have a diagnosed chronic condition, have had a hospital or ED presentation, or be at risk of this. And we actually have some tools that Murray PHN provide in your practices that we can use to help identify who those patients might be. And then we also want to link this to the quality improvement activity that you're already needing to undertake as part of your PIP-QI, or your practice incentive payment quality improvement. So rather than doing multiple things to try and tick several boxes, let's package it up into one way of working, so it's easy for staff to achieve those things they need to achieve around quality improvement, as well as the remote patient monitoring program. So I'm just going to share my screen and take you through a really quick CAT4 recipe. CAT4 through PenCS are the tools that we sponsor as Murray PHN in the region. So in your CAT4 tools, most of the practices we work with are using these tools. If you are not familiar with the CAT4 tools, we have staff that can come out and help you work with some of this data management software, and actually help to narrow down who patients are in lots of different chronic disease or quality improvement activities you might be undertaking. So it's always important to remember to be in the CAT4 tab at the top of the page, and to have a look at your data set in your extracts. I've actually chosen the top data set, which is a de-identified demo data we're going to use today. So I'm going to hide my extracts there and just work with that data set. Now, the first thing we want to do is have a look at patients that are regularly attending practice. So we want to try and capture patients that are often at the practice, and we're going to set this for 6 practice visits in the last 6 months. Some of our practices have actually done a higher number of visits based on what their report tells them, and they've come out with a very high number and they want to reduce that further. So we're going to set 6 visits in 6 months. We're going to go along to conditions, and we're going to choose, for this example, we'll choose that they have diabetes. When I tick diabetes, you'll note that gestational diabetes is not included, and gestational diabetes is not a target group that we're looking at. Often by the time we recognise there's gestational diabetes, they would be nearing the end of their pregnancy, and wouldn't fit in with that long-term view we want of patients' care. So we have diabetes ticked, and then we also want to look at MBS attendance across the top, and we want to actually tick that they have not claimed any MBS item for a residential aged care facility. So I'm going to tick no for that. And then I will need to recalculate my data. And now I'm working with those filters. And you'll see in the middle of the page here, it'll tell us that I'm filtering by 6 visits in the last 6 months with a condition of diabetes with no RACF MBS items claimed. And then I'm going to come down to comorbidities tab in the center of the page and open the comorbidities report. So what it's showing is that I have 66 patients that have 3 chronic conditions diagnosed, which is on top of the already diagnosed diabetes condition. So this is in effect patients with 4 chronic conditions. If I went to the 4 categories, it would be 49 patients with 4 categories. We can have a look at that report. So we can double click it, pull that report out. There it is. And our little report pops out onto our page. So on this page, we've now got 49 patients who have had 6 visits in the last 6 months. They have diabetes, no RACF, and they've got at least 4 comorbidity conditions. And on this page, on your data, it would show the patient's name, who they are, their date of birth, and actually in the middle of the page here, we see that there is a mobile phone number. So this will actually help you identify those patients that already have a mobile phone and just reduce that conversation around saying to patients, do you have a mobile phone? What kind of phone do you have? So it's kind of opening that door up to, yep, we've identified those patients, regularly attended, they've got conditions that might be needing great or closer monitoring, and they've got a mobile phone. This page here, we can also look at top bar prompts. So not every practice is using a top bar prompt, but we could also set a top bar prompt for maybe those patients that are coming in to flag and just say, when this patient comes in, just let the nurse know, we'll have a quick chat to them about remote patient monitoring. The next step of having identified who those patients are and getting a list together is that we can actually write this down as part of our PIPQI activity that practices need to undertake. So most people are familiar with the Plan, Do, Study, Act template that Murray PHN use. And what is it when we develop the PDSA? We're wanting to define what is it we want to accomplish, who will undertake it, by when, and what steps do we need to do. Once we've narrowed down the activity, we can action the plan and review if we did or didn't achieve what we wanted as an outcome of that activity. If the activity doesn't go as planned, or if it does go as planned and the results are achieved, we can actually think about the next step. So the next step in remote patient monitoring might be, we've identified who the patients are. Now, how do we actually recruit them to the program? And then the next step after that might be, how do we actually continue to monitor and engage patients in the program? And we can work with you on developing those PDSAs for further activity. If it doesn't achieve that result of us identifying who our target patients might be, then we're happy to have a discussion about some other ways we could potentially look at who might those patients be that we need to work with. And this is just a really quick template of a PDSA that I've put together around the remote patient monitoring program and how we could actually undertake those steps. So we want to deliver this to 10 patients. How we know that there's a change, we'll actually have those 10 patients enrolled. And you'll notice I've put there, we currently have blank amount of patients. So it's always important when you're undertaking activity to see where you're at the moment. So you might have 2 patients, you might have 8 patients, but it's, be very concrete in understanding the number of patients you've got at the moment, the number of patients you want to increase to. And then we can discharge, if a patient does discharge, we can enroll a new patient because we actually know how to find that next patient. And these are just the steps. So working with those PDSAs, the first one is identify and refine who the eligible patients for remote patient monitoring are. We want to make this QI activity really succinct and really achievable. So this is not the whole program. is not a QI activity. The first step in how we get there is a QI activity. And then we think about what's the second step or the third step that we might need to undertake. So this is just the template. How are we going to do it? We're going to run the recipe. We're going to look at those target areas. Then we're going to work in conjunction with our GP to understand who might be the most suitable and compare our patient records to that list that we've pulled out to actually understand who might have attended hospital or who might be at high risk of attending hospital. Who's going to do it? Our nurses are the big drivers in the remote patient monitoring program, and our practice managers are also playing a key role in that. Of course, we want our GPs more engaged, and GPs love data, we know that. So it's helpful to have a really clear plan and actually show them where we're at and how we're going to get to the number we want to achieve. And then just some other steps in, working to identify the patients. How are we going to do this? We're going to run the CAT4 before the end of July. We're going to present it to our GP either one-on-one or in the clinical meeting and actually have them say, out of that list of 30, I think these 4 are really good candidates. Narrowing it down, comparing it to the patient list, finding who those patients are that have been in hospital. If you would like to undertake running some of these reports in practice, Craig and I will be out in the region, so I'm more than happy to work with you on your data and looking at what your practice data looks like. And I have done these activities with a few practices, and we're finding about 30 to 40 patients fall in that very high complex need group that are regular attendees that might be eligible. So over the 3 categories of chronic disease, we're actually looking at about 120 patients per practice that potentially could fit with this program.
Suezanne, it was great to see how you do your cooking of your recipes for pen system.
I have developed the recipe into a template, so I will send that out to practices along with the PDSA template for the QI activity attached to remote patient monitoring as well. So there'll be a very clear step-by-step, click here, do this, and I think that'll help a lot.
Yeah, that'll be fantastic. Thank you so much, Suezanne. And thank you, Aileen, and thank you, Craig. I really appreciate you sharing your insight, your data and your knowledge around the remote patient monitoring program. And thank everyone for coming along tonight.